So what's the difference between AC and SIMV? The main difference is seen when the patient triggers a breath. So let's figure out how we can tell when a patient tries to trigger a breath. To identify a patient's attempt to trigger a breath, we will look at this graphic. So let's observe a few things. When the patient triggers a breath, you will notice a slight dip at the very beginning. The ventilator will not know the patient is attempting to breathe until the patient reaches the preset trigger. And the term trigger just simply refers to the point in which you want the ventilator to respond to a patient's efforts to inhale. The respiratory therapist is the one that determines this. And once the trigger has been reached, the ventilator will deliver a breath. So let's look at the difference between a breath that is delivered in the AC mode versus the SIMV mode. In volume AC, the AC stands for assist control. And in this mode, when the patient reaches the trigger, the ventilator will assist the patient's effort by giving the set controlled tidal volume. In other words, it assists the patient by controlling the amount of volume the patient receives. What are some pros and cons to this? On one hand, if a patient is weak, but they need a regular amount of volume, the patient only needs to reach the trigger and the machine will take over and give a controlled full volume breath. This mode is good because it ensures the patient always receives a full volume. But there are some drawbacks too. For example, what if the patient wants a smaller volume? Well, in AC mode, the patient cannot change the amounts of volume they receive, and this can lead to hyperventilation and can be really uncomfortable, especially when the patient doesn't want the exact fixed controlled volume. So what should you do? You can switch to the SIMV mode. Just like in the AC mode, if a patient does not trigger a breath, the patient will receive the set controlled volume. However, with SIMV, when a spontaneous breath is initiated, the patient determines the volume. So that means if the patient wants a lower volume during their spontaneous efforts, they will receive a lower volume. In AC, spontaneous triggers results in the set controlled volume. But in SIMV, spontaneous triggers results in whatever volume the patient wants. This gives the respiratory therapist a pretty good idea if the patient can be weaned off the ventilator. If the patient had enough strength to take bigger spontaneous volumes, the weaning might be successful. Well, what if the patient on SIMV can't take a large enough spontaneous breath? Do you need to switch them back? Not necessarily. You can always add pressure support to the spontaneous breaths. And what is pressure support? Let me explain. If you've ever lifted weights, understanding pressure support is easier than you think. If you're spotting someone who is struggling to lift, what you're really doing is you're supporting them. If they need a little help, you provide a little support. But if you have to give too much support, your friend probably should not be lifting the heavy weights. Well, the same principle is true with SIMV. If the patient needs more volume during a spontaneous effort, add pressure support. How much should you give? Generally, a good amount is about 10 to 15 initially, but you can adjust this up or down. Just be careful. If you start giving too much support, like over 20, the patient may not be ready to take spontaneous breaths. So you may consider switching back to the AC mode. So there you have it, AC and SIMV. There are other differences too, but this should be enough to help you get started.
So that's a little review of the different ventilation modes, because you need to understand them when we start to talk about weaning the patient off the ventilator. Now, it's very unlikely that they're going to shut off the ventilator like a television set. So what they'll do is gradually remove oxygen support for the patient, but the patient has to be ready. So they can't be unstable. They have to be improving in their condition, and anything that caused them to be ventilated needs to be resolved. So they can't be an unstable patient. Their blood pressure has to be normal, their heart rate has to be normal, and they have to be in their usual EKG pattern, okay? Their INO needs to be adequate. Their BUN and creatinine need to be within normal limits. They can't have a fever or a new or unresolved respiratory infection. They should be in a decent nutritional state. And they need to make sure, you need to make sure that the drugs that have sedated them and have maybe diminished their ability to breathe on their own have been discontinued or are being titrated down, because you can't put a patient on a ventilator or take them, excuse me, you can't take them off a ventilator if they're too sedated. Their lab values have to be within normal limits, and their ABGs absolutely have to be normal. You do not change ventilator settings and wean a patient if their ABGs are not good. So weaning for patients who've been ventilated for a period of time is usually a slow process, but there are patients who can be weaned rather rapidly. In the next slide, I'm going to show you a picture of this thing called a T-piece, and it looks like a T-piece. It's called that because it looks like the letter T. You might see a patient weaned using a T-piece if, say, for example, they had surgery and they were a bit too sedated post-operatively, and the sedation wore off while they were in the recovery room, and they were breathing on their own. They might do a T-piece weaning right away. It's not common. It's usually the last thing that they'll do right before they remove the ventilator if it's a longer weaning process. What you usually will see is the patient will go on synchronized intermittent mandatory ventilation trials. Well, what they'll do is they will increase the ability of the patient to breathe on their own, or they'll do pressure supported trials. And then there are some patients who just do not wean and end up with tracheostomies and are chronically ventilated. So this is a T-piece, and as I said, it's called that because here we have a T, okay? So one end of the tubing is attached to the is attached to oxygen, and the other end of the tubing is just sort of open to air. Okay, and then this goes into the patient's endotracheal tube. So either patients are quickly weaned using a T-piece, but you usually will see stuff like this done if they're, like in the PACU. Or you'll see a T-piece used right after they finish a whole weaning protocol for a patient and they're just about to extubate them and they want to make absolutely sure that the patient can breathe on their own. So these are some common weaning modes, but I'm only going to really talk about the SIMV. So what will happen is after a patient, let's say, has been on assist control for a while, they'll gradually wean them off of the ventilator using SIMV. And what they'll do is they'll start them off where the patient only has to breathe on their own minimally, so that you can decrease the frequency of mandatory ventilator breaths, and it requires the patient to gradually take over the work of breathing, okay? This type of ventilator mode maintains respiratory muscle strength, which is what you need in order to wean, and normal gas distribution. It reduces the cardiovascular side effects of a controlled or assist-controlled ventilation. However, it increases the work of breathing, and sometimes patients get tired from this. So this is how it usually works. Let's say your patient is ventilated and they are on the following settings. They're on assist control with an FiO2 of 50%, a tidal volume of 600, and a respiratory rate or to deliver 16 breaths per minute. Okay, and when they're on that setting, you're going to get a set of blood gases to make sure that they're all right. So you do that, you get a set of blood gases and everything is fine with the blood gases, and you get an order that says decrease the FiO2 to 40% and obtain ABGs in 20 minutes. So that gets done and the patient is stable and their blood gases are normal. So at 9:15, someone writes an order and they say, begin weaning protocol, change ventilator mode setting to SIMV with a tidal volume of 600. So the tidal volume of 600 is the same and the FiO2 is the same, but we're changing the ventilator mode and we're giving the patient 10 breaths per minute. Okay, so normal respiratory rate is between 12 and 20. 10 is less than that. So what we're hoping is that the patient will be able to make up the difference. So in 20 minutes after the patient has been on this mode, we're going to get a set of blood gases and see if the blood gases indicate that the patient is stable and this is okay. And from that decision, we'll decide whether to keep the patient on this, increase the amount of breaths per minute, or change the ventilator mode back to assist control, or increase the breaths per minute or decrease them. So it can go either way to see if the patient is able to be weaned off the ventilator. But you could see if we put a patient on a ventilator mode and they were doing poorly, we wouldn't want to wait the 20 minutes on that mode and the blood gases in order to make a decision about whether or not they're stable. So you need to assess the patient and see if they're tolerating the weaning. If they're not tolerating, they're going to have a decreased level of consciousness, a change in systolic blood pressure and diastolic blood pressure. You'll see the heart rate go up 20 beats per minute. They begin to develop PVCs. So greater than 6 PVCs a minute or couplets of VTAC, that means the patient is not tolerating the weaning and they should go back to a supported mode. If you see a change in the ST segment of the EKG, the ST segment indicates that the patient is not receiving, the myocardium is not receiving enough oxygen. That's an indication that they're not doing well weaning-wise. If you see the respiratory rate go over 30 or less than 10, so if they just start to breathe and pant, that means they're not getting enough oxygen, or sometimes they just stop. They just kind of, for lack of a better term, poop right out, and they stop breathing. Or if you see the respiratory rate increase by 10 breaths per minute. So if you see somebody who was presently 16 and now they're 26, even though that's less than 30, that's an indication that they're not tolerating the wean. If their tidal volume, which is the amount of air that's moving, is less than 250, that's not enough to aerate the lungs. If you see the PaCO2 go up by 5 millimeters of mercury, or you see the pH is less than 7.3, so that means they're getting really acidotic. If the SpO2 goes less than 90, if you start to see them really use a lot of accessory muscles to breathe, they complain of fatigue or pain or dyspnea, or you start to see any abnormal chest movements where maybe one side is rising more than the other, if they begin to sweat, this is something that happens very frequently when patients don't have enough oxygen. They begin to just sweat profusely. Or they develop severe agitation of anxiety that's unrelieved by reassurance. Now, the thing to remember is that they've been sedated and on the ventilator, and now we're going to decrease or eliminate that sedation and tell them at the same time, oh, by the way, this machine that we've been, having you breathe with, we're going to try to take that away from you. So that's an anxiety-provoking situation to begin with. But if the patient develops severe anxiety or agitation, particularly if they also develop diaphoresis and tachycardia, that means we can't wait for those 20 minutes to get those blood gases. We've got to do something now and put the patient back on the ventilator. So again, common failure to wean criteria is tidal volume that's low. This says less than 100, but that's kind of 100 really isn't much at all. I mean, 100 milliliters of air is like, if you think about 3 little med cups, that's 90. That's not a lot of air, but I'd say 250 is probably a better indication that they're not going to have enough movement of air. ABGs less than 730, PaO2 greater than 50, PaO2 less than 55, and an oxygen saturation of less than 90. And then clinically, dyspnea, respiratory muscle fatigue, agitation, cardiac dysrhythmias, vital signs that become unstable. These are all indications that the patient is not weaning. And I think this is the end of the lecture, so thanks for putting up with me.